Okay. Hello, everyone. Good morning for me, but I know it's good night for you all, or maybe soon. But we'll start here in a few minutes, and everyone can see the slides, correct?
Yes, ma'am, we can.
Okay, perfect. I don't know if Ashwaki or Sindhu, you want to give any introduction about the school or the students in terms of, I know this is majority of you are preclinical or clinical years. Um, and I'll give a little introduction about my background as well. But if you wanted to say something, please go ahead.
Good evening, ma'am. Myself, Nikita Chaudhary, and I'm a final year medical student from India, a very beautiful state, Himachal Pradesh. I just started my final year. It's been 2 months.
Okay, lovely. Okay. Um, so it sounds like, majority of you have probably gone through the respiratory exam with either patients or simulation or given a lecture on the respiratory exam. Um, I don't know everyone's background in terms of how much they know. So please stop me at any time. This is not meant to be extremely formal. This is an overview of the respiratory exam and what you're going to do really from start to finish. Um, Myself, a little bit of background about myself. So I currently work at University of Texas, Houston, and I'm an associate professor for McGovern Medical School. So that's our affiliated institution. And obviously, we teach our medical students the respiratory lecture. We have an OSCE exam that they have to go through. And so a lot of this is based off of um, what they're going to do in that clinical skills exam to really move on to their clinical years and be sure that they can work with patients. Um, so I, did my training in emergency medicine. I think a lot of you will go into varying specialties and fields. And, um, in emergency medicine, we essentially, I have a shift later today that I have to go to, or this morning that I have to go to, but we do the respiratory exam on almost every single patient. And I think the respiratory exam is probably one of the most important because we'll talk about how you can do so much of this exam just by looking at the patient themselves. Um, so I went to medical school in where I'm from in the Midwest in the States, and then trained at Johns Hopkins University in the Northeast, and then came to Texas in 2018. So it's been about 8 years now that I've been in the South. And I met Sindhu, through word of mouth and a lot of your colleagues at a conference in Chennai because I do some work with India. And so if you all have any questions, at any time, again, this is meant to be informal and we can talk through the respiratory exam. Just let me know. I think there's like a raise your hand button or you can write in the comments or interrupt me. I have no problem with that because I understand this is can be a complex topic for some if it's new. If it's just a refresher, then just kind of sit back, relax, enjoy your Friday night, and listen to the lecture. So we are going to get started. So, some quick learning objectives. So, we are going to review the four main components of the respiratory exam, and I'm going to describe the organized approach from start to finish and going through the respiratory exam. Really, again, comparative to our OSCE and what we do in the clinical training skills exam for our medical students, and then understanding any key abnormal findings. You will hear me say a lot. To understand abnormal, you need to know normal, right? Your professors probably say this, your faculty probably say this, but you need to practice this on patients to be able to really hear and auscultate and inspect all the normal findings before you can really pick up the subtle differences in abnormal. And then you're going to apply those to common clinical conditions, but again, really focusing on the normal today and what you should be looking out for. So why the exam matters, the respiratory exam. So you're going to do a rapid bedside assessment, which is what we do in the emergency department to really help localize disease. So I think now in the era of AI and ultrasound in the last 20, 30 years, people rush to grab adjuncts for exams. And I see this with my residents a lot. They'll get so excited about seeing a patient that they will skip portions of the exam that are very critical. And I think going back to your medical training, going back to the basics, it's always going to help you because specifically for the work I do in global health, international health, even like lower resource settings, I've worked in Haiti, I've worked in villages in South and Central America. You're not going to always have these adjuncts, right? And you don't want to be, just like a lot of us are talking about AI in the field right now, you don't want to be a doctor who is dependent on these adjuncts and orders and mnemonics, right? You want to be able to understand pathophysiology of disease and you want to be able to remember it the first time and then keep on practicing it so it's going to build that level of heuristics in your system so that you're not reliant on other things, right? You have this tool of education with you now. So the respiratory exam really matters for this. And it all starts with anatomy in terms of localizing disease. So as you thought you were done with anatomy, but you're never done with anatomy. So we're going to go over quick basic anatomy. This is the lung views in terms of anatomical description, the skeletal, and then again, looking at an actual person and like the surface structures. So by refreshing our anatomy, we're looking at um, where we're listening to, right, in terms of auscultation and how you know where the abnormality is. So understanding the lung exam is really enhanced by recognizing this relationship between all of these surface structures and what's underneath in the basic anatomy. So you see in the first picture, and you see the anterior chest, how much the upper lobes take up of the anterior chest. And then you're going all the way down, posterior view, left lateral view, and looking at the posterior chest, you're even seeing the posterior view is for the majority of the part made up by the lower lobes of the lungs. Okay. And if this is something that you're not remembering, again, you're not going to know where abnormal is, what normal is when you hear those crackles or focal wheezes, or even on percussion, if some of you are still doing that, right? You're not going to know where the abnormality is just because you're not remembering your basic anatomy. So always go back to your basic anatomy. Remembering that the upper lobes are mostly the anterior chest, the lower lobes are mostly in the posterior chest. So looking more specifically at the anterior chest, again, due to this unique anatomy and seeing that the upper lobes are mostly the anterior chest, we see this a lot clinically correlated with something called a silhouette sign. So again, looking at every single normal chest x-ray you have is going to help you determine any abnormal later. Okay, so there is utility in listening to the normal patient's lungs. If somebody comes in with a completely different complaint, again, you're in training, listen to their lungs. You're going to hear normal lung sounds, and that's going to help you identify abnormal later. Look at any normal chest x-ray to help you later identify abnormal. Okay. So here you're going to actually see in this chest x-ray the silhouette sign. And again, why anatomical structure is important, excuse me, is because you're looking at this chest x-ray and you're looking at this obscured right heart border. And when you see an obscured border in the diaphragm on the right side, left side, right side of the heart, left side of the heart, it's called a silhouette sign. And that's really the absence of a silhouette. Okay. So you know that there's actually some sort of underlying mass, some sort of underlying consolidation that's obscuring this silhouette. So this is obviously a right middle lobe pneumonia. Okay. And this is a commonly tested board question we see in terms of like OSCEs, the USMLE, because you're seeing that obscured pattern of the right heart border. Okay. And a lot of times people would think this is either the right upper lobe or even lower lobe, but this is right middle lobe, just based on your anatomy. Looking at the posterior chest, again, you see the left upper lobe and right lower lobe are mainly occupying the posterior chest, right? So it's important, again, to not only look and auscultate anteriorly, but also posteriorly. I tell my residents this all the time. Did you listen to the lungs posteriorly and anteriorly or just anteriorly? Okay. So you want to sit the patient up, make sure you listen and auscultate without clothes on, underneath the clothes, against the skin posteriorly. So correlate clinically, right? We see this a lot in radiology studies, and they'll say, you have the advantage of being bedside with the patient. So correlate this clinically. And again, when you correlate these lobes anatomically, clinically, you're seeing here what on radiographic evidence is actually making up the right upper lobe. So you see an AP and lateral, the right upper lobe, the right middle lobe, and then the right lower lobe. So a lot of times when there's a right lower lobe consolidation, and we see this creeping up on the anterior chest x-ray and we don't get a lateral film just by the nature we can't, the patient can't stand up. So you're getting a portable chest x-ray or you just don't have the capability and you're only getting a one view AP, you're often thinking that this is going to be a consolidation in the right upper lobe. But again, it's not. We see a lot of TB, I'm sure you do as well, that's in the right upper lobe. That could be characterized as being in the right lower lobe if you're not getting that lateral chest x-ray or if you don't know your anatomy. And then again, so I'll go back to this slide. Obviously, you can remember from your anatomy, I'm not going to go over everything, that the right lung has three lobes and two fissures, the major fissure separating the upper lobe and the lower lobe, and then the minor fissure separating the upper lobe and the middle lobe. And then the left lung has two major lobes. The lingula is just the anatomic variant of the middle lobe, so not really considered a lobe, and one big fissure. But you're seeing again how on chest x-ray this could be obscured if you don't get a lateral view. So we're not going to go through too many questions, but just this is a question that's commonly, again, tested on the boards. So if you have a 54-year-old patient that's noted to have pulmonary findings consistent with a pneumonia, so they have a cough, fever, and then they have consolidation, and you're seeing this anatomically in the right axillary line in the fifth rib area, the pneumonia is most likely involving what? So you see the anterior axillary line here would be here, right? Right anterior. And then the nipple line is often, especially in men, where there's not a lot of breast tissue, considered to be the fourth intercostal space. So you're going to go fifth intercostal space here. That's going to be your right middle lobe. Okay, so again, very commonly tested board question. So to understand abnormal lung function, again, we need to understand normal lung function. So areas in the brainstem, we know in the medulla and the pons have groups of neurons that control our breathing, right? So we breathe all the time involuntarily without thinking about it, unless we're concentrating on it, unless we're having an anxiety attack, unless we're meditating, right? We just inhale, exhale on daily basis, right? So if you sit for a second and focus on your breathing and just place one of your hands on your stomach, on your abdomen, and take an inhale and then exhale, what are you noticing? You're noticing that your abdomen is actually expanding, right? Inhalation is active, okay? And it's caused by shortening and the contraction, the downward displacement of your diaphragm, right? A lot of times we think of breathing, inhalation is like chest breathing, and so that your diaphragm will contract and move upwards. But if you're actually just sitting there breathing involuntarily and you place your hand on your abdomen, you're going to notice on inhalation, your abdomen actually expands. So your diaphragm is moving downward, okay? And that's what's happening when you inhale, and that's for oxygen delivery. And then we all know the purpose of lung function is for gas exchange, right? And then on exhalation, this is more passive and it occurs when the diaphragm and the intercostal muscles relax, okay? So some pulmonary terms. I don't like slides full of text, but this is going to probably be my only one. Just applying this clinically, a cough, right? These are the common symptoms. That's a reflex response to stimuli that irritate our receptors. So again, breathing is involuntary by centers in our midbrain. And the reflex of a cough is actually the receptors from our larynx, trachea, and bronchi, okay? And that's if you have a mucus plug, if you have a bronchitis, and then any external air agent. We see this a lot in allergies, allergic asthma, allergic rhinitis, and then you can trigger this cough. Very important to know for patients who can't trigger a cough. So patients with neuromuscular disease where their cough reflex just is not as strong. Okay. We see in the acute setting, cough is lasting less than 3 weeks. So you're thinking more viral upper respiratory infection. For the emergency department, this is very, very important to know because patient education. So you want to educate patients that, we think this is a bronchitis. So we might treat this with azithromycin if you have underlying emphysema or obstructive lung disease. But if this cough goes on for longer than 3 weeks or even longer than 8 weeks, you need to do this, this, and this, maybe get further imaging with your primary care doctor or something else, right? Because this has now become a chronic cough. Subacute cough is that term 3 to 8 weeks, and then the chronic lasting more than 10 weeks. And this is usually seen in either cancer malignancy or chronic bronchitis, postnasal drip, and then obviously GERD as well. Pulmonary terms continued. So dyspnea, um, I think dyspnea is probably one of the most telltale signs that something is wrong with your patient. This is one of those respiratory symptoms on the exam and signs of a patient that you can see if you sit there and observe. Okay. And this is that non-painful breathlessness. So it's really, really important to watch for dyspnea. This is this like uncomfortable awareness of a patient's breathing, where it just doesn't seem involuntary anymore. They're concentrating it. It's also called, they say they're short of breath, right? But it can be a wide range of meanings, right? And it can mean a patient has a pulmonary embolus, they have a pneumonia, they have a bronchitis, they have emphysema, asthma, they have malignancy, but we know it means respiratory discomfort. And often for me, this is a telltale sign again to pay attention for impending respiratory distress. So many, many causes of dyspnea. I think one of the most important things to know is that dyspnea is like anemia, right? You can treat it with supplemental oxygen, with beta agonists and albuterol inhalation, with so many different things. But it's a sign, it's a strong predictor, especially in emergency acute visits, of mortality. It's a strong predictor of mortality. Okay. So a lot of prevalent conditions in terms of like metabolism, sepsis, DKA. We see a lot of dyspnea, right? We see Kussmaul respirations. So it can trigger something that's not related to pulmonary pathology. So you really need to be creating this broad differential as we see here. Um, Dyspnea and end of life care, you often see patients will tell you it's kind of like a pain or discomfort like no other. And the whole goal is to reduce the sensation, but again, a strong predictor of mortality. So your dyspnea assessment is for airway diseases, parenchymal diseases, pleural diseases, and then pulmonary vascular disease. So all the way from truly the oropharynx coming to the larynx, to your bronchus, to your bronchioles, beyond your trachea, looking into your vesicular and then parenchymal diseases. The pulmonary history. So what kind of questions are you going to ask? Again, majority of you know this. You've probably asked a lot of these questions. You're going to ask about the main complaint. This is going to be open-ended. If the patient's not telling you after you've given them, 5 minutes to speak open-endedly, then you can ask targeted questions about intensity, when it becomes more severe, the circumstances that led to this, travel, secondhand smoke, things like that. Always ask about the treatments tried. Patients might tell you that they've used their nebulizers at home or their albuterol inhaler at home, sick contacts again, or travel history, and then past medical history. And then you're going to want to ask about family history, specifically where I work. Things again like travel is very important to South and Central America, lung diseases in the past, immunodeficiencies, and then cancers in the family. And then social history in terms of like, if this patient has been in jail or prison, if they have had an occupation that exposes them to asbestos, if they have had an exposure to tuberculosis, things like that. And now we're going to go over the 4 components of the respiratory exam. So this is really by original textbooks. how you can organize yourself methodically. I do want to point out that this is more, it's supposed to flow rather than be so rigid in terms of the four components. So don't always think, again, write this down and with each patient have to go three or four components. Just remember it, memorize it, and then use it to your advantage in terms of what is important for this patient. So, how much of the respiratory exam or lung exam can you perform just by standing at the foot of the bed? Um, my residents will initially, when I ask this question, say not much. But you can do a lot of the respiratory exam and gain a remarkable amount of information just by watching a patient and looking at their breathing pattern. Okay. Are they distressed? Are they labored? Are they diaphoretic, which is not even related to the respiratory exam? Are they seated? Are they laying flat? Are they seated forward in a tripod position because they can't lie flat? Um, you can tell so much about pathology just based on looking at the patient. Okay. Can they speak to you? Are they stridorous? Is their work of breathing increased? Again, a lot of this is dependent on practice and how much you practice. So, again, this will take seeing a lot of patients. So, again, you're looking at respiratory rate, their general comfort. Are they uncomfortable or sensing a lot of discomfort? Or are they breathing comfortably and telling you that they are very short of breath? Look at their pattern. Is it Kussmaul respirations, their position, their ability to speak, and then use of sternocleidomastoids or accessory muscles. For kids, it's really important in pediatrics to always lift up their clothing and look at subcostal retractions. So the exam structure, the four components that I'm talking about, it's the IPAP framework. Again, be a little bit more flow. You don't have to be so rigid about this, but you want to inspect, look at the patient, um, and then palpate, feel, and then auscultate, and then percuss. Okay. So again, you're not going to percuss on every single patient. You're not going to palpate the chest on every single patient. Um, but you just want to make sure to be able to go through these steps at least when you're learning the respiratory exam on your first few set of standardized patients or your first few set of patients that you see so that you know how to do these exam maneuvers. We always joke, you might see, Instagram videos or TikTok videos about this, whatever social media app you use, that medical students are the only people that actually go through the IPAP framework. That's probably true, right? I'm not percussing on every single patient I see in the emergency department, especially when we're in, a disaster situation with patients. But it's important that you know how to do this. And if you go through your entire career, 20 years down, and you have no idea how to do this because you never did it during your medical training, well, that's unfortunate. So now's the time to learn. So inspection is going to, again, that observation period. So you're looking at the chest wall. What is this patient's breathing? Palpation, what does the chest wall feel like when the patient's breathing? How much are they expanding? Auscultation, what do I hear when I listen with my stethoscope? And then percuss, what do I hear when I am not listening with my stethoscope and I percuss the chest wall? So when you're looking at inspection, you're looking at the respiratory rate and pattern, the work of breathing, chest wall symmetry, how symmetric is it expanding, use of accessory muscles, and then on your next patient you see for everybody, I want you to actually sit and count the respiratory rate. Do not, it's always a trust but verify. So what's recorded in the EMR, the medical system that you use, it might be 16 or 18. I want you to go to the bedside and sit for 30 seconds and multiply it by 2 or 60 seconds, a full minute, and count the respiratory rate on that patient. Okay. It's really important you know how to do that. And then remember the definition of tachypnea. So this is 20 breaths per minute or greater. Okay. So it's not 25 or 26. It's actually the definition of tachypnea for sepsis, for dyspnea, for really anything. The abnormal vital sign for tachypnea is 20 breaths per minute or greater. So you're going to inspect the chest wall, again, looking anteriorly and posteriorly, looking for symmetry, look for deformities. Here is somewhere that you're looking at a patient. They have, this cavitary chest. This is pectus escavidum. You can see this on a chest x-ray, and then you can see this on the patient. So this is something you've noticed as you're inspecting the chest. Another abnormality or pathology is the barrel chest. So you see on the lateral view of the chest x-ray, a very wide diameter in terms of the anterior and posterior diameter. And you can see on the patient, it's a barrel chest. So you're thinking about COPD already. So, what is the following correct order after inspection? We'll go through this quickly because we just talked about it. This is palpation, auscultation, then percussion. So, the big idea for the next three steps is that all abnormal lung findings are going to result from changes in either air, fluid, or tissue, right? Lung is made up of air, fluid, and tissue, and that's it. So, anything abnormal that you're going to hear on auscultation or percussion is an abnormality in one of these three substances. So palpation. So we talk a lot in medical school about tactile fremitus, respiratory expansion, tracheal position, like these things like whispered petriloquy and egophony. Um, you should know how to do them. You should watch videos on how to do it. You should do this on your next patient. Obviously, you're not going to do this on every patient, but when you're starting in clinical training, you should really start to inspect and feel and palpate the chest. And you're going to start posteriorly and go down the chest. Okay. And again, what you're going to feel for is really that vibration and sound transmitting through solid tissue. Okay. So, what does it feel like when a patient is speaking? So, the way you do this is actually place your hands on the patient. So a little bit higher than where this instructor has a patient, hands on their patient now. And you're going to ask the patient to say 99. Um, and you're going to go down the chest wall in three different areas to feel tactile fremitus. And again, you're not going to know abnormal until you feel normal 100 times. Okay. And tactile fremitus is really that low frequency vibration that you're feeling on the chest wall by the patient's speech. Okay. And so you can take like the corners of your hands and place them on the patient, or you can take the palm of your hands. And the key concept is that sound is going to travel better through solid tissue than it does otherwise. So if you have solid tissue, such as a malignancy or pneumonia, you're going to get increased fremitus or increased vibration on your hands when the patient's saying 99. Okay. And you're going to have decreased fremitus if there's air or fluid. So if it's COPD, if they're hyperexpanded in terms of their chest, if there's pleural effusion, most often transudative, or if there's a pneumothorax. Okay. Auscultation steps. So the technique of auscultation, obviously, you're going to use your stethoscope. Your earpieces, I'm going to go through this really basically, are facing anteriorly. We see a lot of people still do this incorrectly. The diaphragm of your stethoscope, after you place your stethoscope earpieces in your ear facing anteriorly, you're going to scratch it and just warm it so you can make sure that it's on the right setting, that it's not on the bell setting. It's actually on the diaphragm setting to where you're listening. Okay. Sorry. Um, and then you're going to place the diaphragm firmly on the skin, not through the clothes, so that it is not moving with breathing. Okay. So you're going to make sure that it's not moving, that you're not hearing the sounds of you moving the stethoscope. It's just going to be firmly on the skin so you hear the patient's vesicular or bronchial breath sounds. And then you're asked the patient take slow, deep breaths through their mouth. Okay. I always again say this, listen to the posterior chest first, because this is going to capture the most pathology. You're going to get the upper lobes and the lower lobes in just listening to three areas on both sides of the chest. Okay. And then when we're teaching our students to do the clinical skills exam, the only way for them to pass is if they truly listen to three sides or three areas, excuse me, on each side of the lung. Okay, so you see here in the posterior view, they have to listen to 4, 5, 6, 7, 8, and 9. Okay. Normal breath sounds. The tracheal breath sounds, again, this is everywhere. So a lot of times when you're trying to assess for stridor, if you're thinking something might sound stridorous, but you don't know if in pediatrics the kid is just, it's a croupy cough, or if there's something else going on, you want to listen over the trachea, and then you want to listen over the bronchi, and then bronchovesicular breath sounds. And then when you get to the lungs, you're going to hear actual vesicular breath sounds. So when on your next patient, I want you to listen to all four: tracheal, bronchial, bronchovesicular, and then vesicular breath sounds. Vesicular is going to be your normal lung fields. Bronchial, that loud, high-pitched sound, it's because of the trachea. So it's going through a tubular structure. So you're going to have a little bit more turbulent flow. It shouldn't be too turbulent. That's concerning for obviously stridor or some sort of really narrowing of the airway, but it's going to be normal over the trachea. If you hear that loud, high-pitched sound over the vesicular lungs fields, that's abnormal. Transmitted voice sounds. So if you have increased transmission with infiltrates, you're gonna hear that, right? Because the lung has become airless now. Air is now occupied by some sort of solid. So the sound is just gonna increase, okay? And then again, that bronchophony, you can ask the patient to say 99. You hear this louder, just like in tactile fremitus, you would feel it more clearly. And then you can do this with whispered petriloquy and then also egophony. So egophony really is just, if you're going to remember it, remember it's when you're auscultating in all of your different areas, anterior and posteriorly, ask the patient to say E, and you're actually hearing ah, okay, or A. So you're hearing a different sound than E, okay? You're either hearing some form of ah or A on your stethoscope, but you know the patient's saying E, okay? So we're going to listen to a few normals if these work. I really like this website, especially if you've never heard abnormal breath sounds. So normal, this is what you're going to hear if you haven't heard them. I can recycle. We'll play it again. Okay, and then a wheeze, which you'll often hear. You can have a cardiac wheeze, so you may not have obstructive lung disease, but wheezing, obviously, you're gonna hear with more of the hyperviscous or like hypermucoid diseases like asthma, a lot of obstructive lung disease like COPD, emphysema. Can even hear this with chronic bronchitis. In pediatrics, you hear wheezes with reactive airway disease where they may not have asthma yet or diagnosis or even bronchiolitis. If you can hear it and expiratory, you can hear that wheeze. And then crackles. So this, so that one you're actually hearing crackles on the inspiration and then a slight expiry wheeze. So I can send out this website after, but it's great. It's on YouTube. It's available, and it's showing you many, many different normal and abnormal lung sounds. Mm, We will. Sorry, pause that one. Okay. So percussion, the normal lung sound is going to sound resonant. Um, Dull is going to be more consolidation. It kind of sounds like the liver, because obviously there is a different parenchymal structure there. And then it could be an effusion. Then hyperresonant is where there's more air. Obviously, air is filling where it shouldn't be. There should be lung parenchyma. And so it's going to sound hyperresonant. So how you're going to percuss, this is a great depiction of how to do it. Ask your attendings the next time you're on shift, or just try this. You can always YouTube it, Google it, but you're going to go at the edge of the scapula. It's easiest to do this posteriorly, obviously, because of the liver, abdomen, and then breast tissue. But you're going to go laterally to the vertebral column at the edge of the scapula and use your distal interphalangeal joint, so the DIP, with your left middle finger. And then you're going to percuss, okay, with that tip of your right. So you typically you'll use your index finger on the right, and you're going to go down on one side, and then you're going to move to the lateral side, starting at the top again, and percuss again. If you have a flat sound, again, this could be an effusion, a dull sound, consolidation, hyperresonant, more air, pneumothorax. Again, practice to get proficient. You will not know normal until you know abnormal. The passive hand, your left hand, should be firmly against the patient's body. This is another depiction of percussion. And then your active hand is striking that DIP several times, and you're listening. So the room should be quiet. Common clinical patterns, again, putting this all together, right? So your auscultation, your inspection, your palpation, and your percussion. When you hear dullness when you're percussing, and then you hear crackles that are focal, you're thinking of a pneumonia. If you're hyperresonant sounds plus absent breath sounds, you're thinking of pneumothorax. This is important for medial sinus shift, tracheal shift, and then it might be a tension pneumothorax based on the patient's physiology. And then a diffuse wheeze, thinking more asthma, COPD. But again, this is not limited just to this. So again, you have to know all this anatomy to be able to diagnose pathology and so much more later. Here is a great, you can take a picture of this, but like here's a great full lung exam from start to finish. They kind of go through, Stanford Medicine does great videos, and they go through start to finish the lung exam, think about abnormals, normals. And then again, I can get you guys that YouTube, but it's really just sound bites of normal lung exams and abnormal. Key takeaways. So you want to be systematic, but don't be too rigid. Thinking about inspection, palpation of the chest. So you want to palpate the chest wall anteriorly and posteriorly, and then auscultation and percussion. Always compare your sides, okay? And then think air fluid or tissue when you're thinking about abnormalities on auscultation, inspection, palpation, percussion, or imaging. And then biggest point I can tell you is practice improves. You actually want to be good at this. Don't run for the ultrasound or don't run for imaging in a chest x-ray before you can diagnose things. Try your hardest in these clinical and preclinical years to assess your patients from start to finish so that you are actually practicing good medicine. And that's it. And these are my references. So if anybody has any questions, I can take a few questions.
Thank you so much, ma'am, for that brilliant, clear, and clinically rich session. I am Sanskruti Rathod, an MBBS intern from India and a member of Events and Research Committee of MCH. On behalf of MCH, the Association of Future Surgeons, I thank you for your time. I'm sure everyone has gained practical insights that will directly improve bedside examination skills. Before we move on to the questions, a quick note about MCH. MCH is a growing academic community of medical students and future surgeons dedicated to clinical skill development, research, mentorship, and leadership in surgery. And sessions like today's reflect a commitment to meaningful learning. We will now move on into the interactive question and answer segment. So, participants, this is your moment. Please drop your questions in the chat box and I'll be happy to read them out for Dr. Walia.
All right, I'm trying to look at these chat questions. I think I might have to stop sharing to do the chat.
Hello, ma'am. Thank you for the interactive session. I don't have any question now, but the way you teach is really very nice. So thank you so much.
Of course, of course. I'm glad you all, some of you maybe got something from it. I think that's the most important thing. You guys, this is your time to learn. This is your time to really understand and dig your feet into the pathophysiology. And so I think it's really, really important for you all. And I think that's how you're going to, become better doctors who can do a good bedside assessment later in the future.
Yes, ma'am. Ma'am, I want more a session like from you, like on the for radiological examination. For example, sometimes we are very confused while interpreting the chest X-rays in cases of pneumonia, asthma, and COPD. So how we can go for that? Sometimes the signs, symptoms, and the findings are the same for the medical students, and it is quite tough while in examination.
Yeah, I agree. I think it can be difficult. What I would encourage you to do is look at every single imaging for your patients. Again, I'm trained emergency medicine. I was never trained to be a radiologist. And so initially, when I was starting my residency training, I thought, why do I have to look at the images? That's what you have the radiologist for, right? But my attendings taught me it's so important to open every single CT scan, open every single X-ray. You will find things that a radiologist misses. We're all human, but at the same time, it's important to know um, you're the person at the bedside, and so you know where the patient has the abnormal findings on your exam. And so you're looking at that portion. And again, you're not going to be able to tell if something's abnormal unless you go through 100 normal chest x-rays. Okay. And so I think that's the biggest difference is that when you see all these normals, now, for example, when I go to shift later today, I sign about 100 EKGs on a shift. And so when I look at an abnormal EKG and a tech brings me that EKG, I know right away it's abnormal within seconds. Now I have to do a little bit more digging to figure out what's abnormal about it. But when you see so much normal, you're going to know abnormal.
Okay, ma'am. Thank you so much. Ma'am, one last more question. That one of my professor in my college said that respiratory system is the graveyard for physician because it is very tough to, the cardiovascular system and the respiratory system has always presented with the same complaint. So it is a bit difficult to differentiate either the pathology involves the respiratory or the cardiovascular system.
It is, yeah. It is difficult, but again, I think it's because we saw there's such a wide differential. And the biggest thing you can do, or the biggest mistake you can make, is anchor on a diagnosis, right? You have to be curious. Um, you have to take that throughout your lifetime. If you're not curious, just drop medicine right now. Drop it all together. Okay? Because you are training to essentially be a medical detective. That's what you're training to do. It's not to get the answer right. It's not to be right all the time. When somebody corrects you, that's great. They've just given you they've shed some light, right, on what this patient could have. So I think medicine teaches us a lot, whether we like it or not, to shed our ego completely of anything related to, I got the diagnosis. I'm so happy I got the diagnosis. I've saved the patient's life. That's obviously the goal. But keep your differential wide. I tell my residents this all the time. When they start their first day intern year, I say, you're not allowed to tell me a plan unless you tell me at least 5 things that could be wrong with this patient. Because the smartest residents that come in and they know the exact diagnosis, they are going to end up making so many mistakes in their career because they're not thinking wide and they're not thinking broadly. And I think that's what hurts the patients most. And that's the oath we all took, right? Is to help the patients. So I think that's the most important is always keep your differential wide.
Okay, thank you, ma'am. Thank you so much.
So we have a question from Dr. Raghav Bansal. The
Yes.
question is, what is the significance of AP and transverse diameter of chest in examination?
I'm not sure I understand the question. What is the significance of the anterior posterior diameter of the chest? Is that the question?
Yes, what is the significance of AP and transverse diameter of chest in examination?
So again, it's just about inspection, right? So we saw like if you're looking at a patient from their lateral view and you see a barrel chest or you see a mass or you see an asymmetrical involvement of the right lateral chest or you see chest swelling, this is all pieces of information that's going to help you, right? Again, a lot of times we anchor. Somebody could be dyspneic because they have multiple myasthenia gravis, and it has nothing related to their pulmonary. Their lungs are perfect, but it's their chest wall that is weak, right? That's a neuromuscular disorder that's causing dyspnea. Somebody could be dyspneic because they have a pulmonary embolus. Somebody could be dyspneic because they have COPD and you see a very barrel chest. So the significance of completing the entire exam is getting used to a structured approach and an organized approach while you're in the stage of learning so that you can recognize abnormals and not just say, oh, this patient has shortness of breath, it's asthma. Oh, this patient has shortness of breath and cough, it's pneumonia, right? Because it's not the patient's job to tell us. That is one of the biggest problems I think with medicine today is when we say things like this patient is a poor historian. You see that all the time on, you know, blogs and feeds and again on social media. The patient's not a poor historian. It's not the patient's job to give us the history. It's our job to get the history. However, we do that by calling the family, by doing a better exam. The patient might have dementia, schizophrenia. I mean, we don't know. They could be delirious. They could be in DKA. be hyponatremic. It's our job to use all of our exam techniques to figure out what's going on with the patient. So the significance is to understand normal so you understand abnormal.
Okay, I hope Dr. Raghav is happy. We have one more question from Ishita Sinha, and she asks how to form differential diagnosis after a respiratory examination.
Yeah, I mean, I think that's a bigger question because I think it's how you form your differentials in general, right? There's a lot of different mnemonics out there. There's a mnemonic Vindicate, where you can go through vascular, infectious, neurologic causes. Um, so, it's whatever structured approach that you want to use. Um, I think from a differential perspective, your job right now is to sit there, go back to your history and physical, what the patient told you, and then what you found on your exam, your objective components, and put together everything that could possibly be wrong with the patient. Okay. Everything. So you're thinking, exhaust your differential. Think of 10, think of 20. It doesn't matter. But the most important is to go through a methodological approach. Again, like I don't have the best approach for you. There's so many out there. Um, but you have to look at your history and your physical and then think about so many different causes. Like I said, infectious disease, vascular, neoplastic, and malignant, obstructive causes. There's so many different things, right? And your history and physical is going to help you with that. And then I think somebody said the link isn't working because the hyperlink is only on up to Stanford ME, but it's supposed to be Stanford Medicine 25. Like you're supposed to copy the whole to HTML. Well, I thank you guys so much for listening, and you all are going to be great. And I hope this helped a bit.
Thank you so much, ma'am, for answering all the questions. As we come to the end of this wonderful session, I would like to extend our heartfelt gratitude to Dr. Shabana Walia for sharing her time, expertise, and inspiring guidance with all of us today. Ma'am, your session has truly strengthened our understanding of respiratory examination in real clinical practice, and we are deeply thankful. A big thank you as well to all our enthusiastic participants. Your presence and interaction made this session even more meaningful. Before we sign off, a quick reminder to join our official MCH community, visit our website for upcoming academic events, register as a member to receive your participation certificate. We have shared the links to join MCH and the website link as well. We have also shared the feedback form for this session. I request you all to please fill the form. We can't wait to see you again in our future sessions. Thank you once again. Have a fantastic evening ahead and keep learning, keep growing, and keep inspiring.